learn and work together. So I would like to thank them all. We had hard time with this COVID crisis, and even the part of hearing about our colleague and our patient if they get COVID. Uh, I will go through a few cases from what we saw in the last few months from the COVID patient to show some difference in the variety and the presentation, some of the complication and sequence of the disease. We will not go in the deep or detail about the case, but it's a few cases we will present it. And as we know, the majority of the case of COVID-19, they are either asymptomatic or they have mild symptoms. They are not requiring hospitalization. But we will go through a few cases who's requiring his hospitalization due to COVID or their its complication. And as we mentioned the question, we will leave it at the end of the second presentation with Dr. Nisreen, inshallah. Our first patient, he's a 43-year-old male patient. He's medically free, presented to the ER with history of fever, cough, and mild shortness of breath in exertion. His symptom was for the last persistence for the last 2 days prior to the admission. He had history also of contact with COVID positive patient. In the examination, he had bilateral crepitation in the chest examination along with documented fever in the hospital. Day one X-ray shows some peripheral change in the X-ray. That time, the patient, his vital sign is stable apart from documented fever. But later on the day 3 of the admission, he had worsening in his X-ray, worsening in his symptom for the shortness of breath mainly, and he required oxygen supplementation. His workup, he's not having any leukocytosis, but he have lymphopenia from the beginning. He had high inflammatory marker, high CRP, ferritin, and LDHD dimer. This investigation, we usually follow it in the COVID patient to predict either the severity or the progression of the disease. As you see, in the day 3, all of his parameters start to increase. And even we think about what we call it in the COVID cytokines storm. So this patient here received supportive care and he received tocilizumab for this cytokines storm and he received also antibiotic. So this is the first case we presented to show this patient is not having any risk factor to have severe disease to start with from the beginning. And you can expect severe disease in the healthy patient also. The second patient, he's a 64-year-old male patient, known case of hypertension, hepatitis C virus. He has liver cirrhosis. His status post-liver transplant around 1 year back and presented also to the ER with a history of fever, cough, and shortness of breath. He had bilateral crepitation in examination. This patient, I brought his X-ray and his image mainly to see. It's almost the same presentation of the previous patient with this history sequence event happened during the hospitalization. This patient is a start to acquire oxygenation. He has worsening in his lab and in his X-ray. As you see, this patient, he had X-ray before his admission, actually, during one of his outpatient follow-up in our hospital, which totally good comparing to the X-ray at day of admission and the X-ray after one month from the hospitalization. This X-ray is showing the complication and the sequence after the COVID infection. This patient here requires oxygen supplement till reach non-invasive ventilator support. Also, he had CT chest after 1 month from his hospitalization, which showing this destruction of the chest, destruction of the lung, and we call it post-COVID complication. Usually, sometimes it ends by lung fibrosis, and as we read in the literature, some of the patients required even lung transplantation. So he gets supportive care with non-invasive ventilation. He gets antibiotic, antiviral, steroid, and tocilizumab. This patient is in by home oxygen, actually. We will go to our third patient. He's a 25-year-old male patient. He's a smoker. He was diagnosed as a COVID-19 with mild upper respiratory tract symptoms and isolated at home. Presented around 1 month later with history of chest pain, mild shortness of breath, with unremarkable examination that time. His chest X-ray was normal, echocardiogram, his CBC and all of the inflammatory markers within normal. His cardiac enzyme also within normal. This is his ECG, time of the admission, showing even ST elevation, diffuse ST elevation with some BR interval depression in some of the lead. With this history and this ECG finding, the possibility of pericarditis is raised and the patient diagnosed as pericarditis post-COVID infection, and he received the management of the pericarditis. He gets colchicine and aspirin that time, and he's following with the cardiology after that. This patient we presented to highlight the extrapulmonary manifestation of the COVID after we present 2 cases of the pulmonary involvement with post-COVID complication of the pulmonary system. But now that we get COVID presentation as extrapulmonary manifestation with the cardiac manifestation range from the pericarditis, myocarditis, even sometimes myocardial ischemia. The last patient I would like to present it. She is a 48-year-old female, a known case of hypothyroidism, bronchial asthma. She was also diagnosed with COVID-19 2 weeks prior to her admission. That time she had fever, headache, and myalgia, and she lost her smell. She did not require that time any admission to the hospital, only it was outpatient visit and isolated at home. 2 weeks later, she presented to the ER with a back pain, which is radiated to the legs and associated with the numbness. And also she started to have lower limb weakness, which is progression, and start to prevent her from daily activity. That's what brought her to the ER that time, and no other neurological symptom. The positive finding in her examination, she had bilateral ptosis, and her power in the lower limb is 2/5 and upper limb is 4/5 with reduced reflexes in the examination. Her MRI is showing some enhancement in the facial nerve and quadricular nerve root, which is this finding suggests of Guillain-Barré syndrome or other post-infectious polyneuropathy. She had CSF analysis, which show 0 WBC and high protein that time. All of her culture and PCR were negative. With this high protein and normal cell count, which going with protein cell disassociation, it's again going with the possibility of Guillain-Barré syndrome. She underwent also nerve conduction study, and her finding in the nerve conduction study is in favor of the Guillain-Barré syndrome. So this patient diagnosed as Guillain-Barré syndrome post-COVID. She received IVIG and she get plasma exchange that time. Also, this case presented to highlight the CNS involvement due to COVID, which had again a range of the manifestation in the CNS system from the encephalitis, stroke, sometimes seizure, and like Guillain-Barré syndrome in our case. So I present 4 cases of COVID-19 patient who has pulmonary and extrapulmonary manifestation to highlight the variety of the disease and the presentation. I would like to thank you for listening, and I will let Dr. Nasreen to complete the second part of the presentation. The question, we can keep it to the end. Okay, Dr. Nasreen.
Hello?
تفضلي دكتور نسيت، تفضلي. Sorry for that because there's I think technical problem, but now it will be solved inshallah.
Hello?
تفضلي دكتور.
Can you see the slides?
Yes, but you can put the slideshow and you can start.
I shared the screen, but it's not coming to me. Have some technical issues, so just be patient with me. So is it clear now?
Yes, Doctor. You can put only slideshow from the PowerPoint. Yes, okay, it's clear now.
Okay. Sorry for keeping you all waiting. It was there was some technical issues. So thank you very much, Dr. Aid, for presenting these varieties of cases from our services. The patient we've seen the COVID patients we have seen during the service. So this part will be about the overview of COVID-19 infections. I would like to express my gratitude to the Department of Continuous Education, their director, Dr. Sultana Zaidi, for restarting this important educational activity. So without further ado, these are the objectives that I will try to cover during my talk. As a beginning or as an introduction, I will just talk briefly about coronaviruses. Coronaviruses are single-stranded RNA viruses that belong to a family called Coronaviridae, which is subdivided further into 4 genera: alpha, beta. Those both originates from bats, gamma originate from birds, and delta from pigs. All coronaviruses have envelope that encase the RNA genetic material. They are different in shape, round, oval, or polymorphic, with a diameter of 50 to 200 nanometer. There are 6 types of coronaviruses that previously known to infect humans. 4 of them usually cause self-limited common cold infection. And the 3 of them, which were the cause of the pandemic in humans, are all belong to beta genera coronaviruses. The first coronavirus that caused pandemic or outbreaks in human is the SARS-CoV, which starts in Asia and then spread to East Asia in 2002, and it was associated with case fatality rate of 10%. 8 years later, MERS-CoV appeared, Middle East Respiratory Syndrome coronavirus, and it caused a pandemic mainly in Arabian Peninsula, Saudi Arabia, Gulf countries, and some Mediterranean countries. And it was associated with case fatality rate of 35%. And the last one is SARS-CoV-2, which is the cause of COVID-19 pandemic. The global case fatality rate is between 1 to 4%. And as you can see, SARS-CoV-2 is a little bit has lower pathogenicity as compared to SARS-CoV-1 and MERS-CoV. However, it has a very high transmissibility or transmission rate. All coronavirus in human involve mainly the respiratory system. The symptoms varieties ranging from mild common cold-like illness to severe pneumonia that might be complicated with ARDS, sepsis, septic shock, and multi-organ failure. However, as Dr. Eid mentioned, extrapulmonary manifestations are not uncommon in many patients. So as I just said, the coronaviruses causing pandemic in humans originates from bat. The infection in human is speculated to be due to direct contact with bats, but more commonly through a spillover to an intermediate host. For example, the intermediate host in SARS was the palm civet. In case of MERS-CoV, it was the dromedary camel. And in case of COVID-19, it is not identified well, but most likely thought to be pangolin and some types of snakes. The characteristic feature of coronaviruses in general, they have the ability to cross the species border. That's why they have the potential to cause pandemic or outbreaks in human. So by now we know that coronavirus is the name of the disease. It stands for COVID-19. It stands for coronavirus disease infection that occurred at the end of 2019. And the SARS-CoV is the name of the virus causing this pandemic. The name given to SARS-CoV as this because it has similar genetic similarity of around 80-85% to SARS-CoV-1. And it also carries a genetic similarity of 50% to MERS-CoV. And up to 95% or more genetic similarity to coronaviruses found in bats. This drawing simplifies the structure of SARS-CoV-2. It is a round in shape virus with diameter ranging between 60 to 140 nanometer. It has 4 major proteins: the spike protein or the S protein, which is located on the surface of the virus, and it forms like a rod-like structure. It's responsible for giving the virus or the virion its crown-like appearance. By the way, in Latin language, corona means crown. More importantly, is for this protein, it functions or it helps the virus to enter the host cells by attaching to the angiotensin converting enzyme 2 receptors. The second protein is the M protein or the matrix membrane protein. It is the most abundant viral protein, and it acts as a central organizer for the coronavirus virus assembly. The third one is the E protein. It is the smallest protein, and it plays multiple functions, including pathogenesis, assembly, and release of the virus. And the fourth protein is the N protein or the nucleocapsid protein, which facilitates the M protein interaction during the virus assembly. In this slide, we'll just go through some of the major events occurred in COVID-19 timelines. The first clusters of cases occurred in China, Wuhan city, was on 8th of December. It was announced by the China health authorities, and the number of patients were 41 cases, and no cause was found for these cases of pneumonia. 2 weeks later, they have another clusters of cases of 27 patients. Again, no cause of pneumonia were found. Both clusters have a link to China, Wuhan city seafood market. So by 1st of January 2020, China government closed that seafood market. On 5th of January 2020, Wuhan Health Committee exclude also SARS and MERS as a cause of these cases of pneumonia. And in 7th of January 2020, it was the first time that the virus isolated by culture. So in 8th of January, China CDC announced that these cases of pneumonia that occurred in Wuhan city are all related to a novel coronavirus. At that time, it was just called novel coronavirus 2019. 1st of January 2020, the genome of the virus was identified. And because of the cases started to increase rapidly to spread outside China, to Japan, Korea, Thailand, etc. By 30th January 2020, WHO declared it as public health emergency of international concern. Then 2 weeks later, 11th of February 2020, WHO names the disease as COVID-19 and the virus causing it as SARS-CoV-2 by the International Committee of Taxonomy for Viruses.